Hi, Dr. Atiee.
Hi, can you hear me okay?
Yep.
Hi, JD.
Hey, how's it going?
Oh, it's okay. How about you?
Not too bad. Busy day, but we're wrapping up things.
Okay. Well, I don't know if anyone else is going to join us. It might be a very intimate discussion.
Oh, can't wait.
Um, I don't think it'll take very long. I don't know if you had a chance to read the paper, but it's not going to be earth-shattering.
That's okay. I'm sure we can come up with stuff to talk about. We'll make it
Yeah,
fun.
yeah. Okay. Summer, do you want me to just get started so that
It's honestly up to you.
okay.
If you want to go ahead, you can. It is recording, or a lot of times people do join like within the first sort of 5 minutes. So if you want to give it a minute or two, that's up to you as well. Honestly, either way is fine.
Okay. We'll give it 1 minute.
Okay.
And
Just
then
whenever you're ready, proceed.
move on. Okay, I think it's been a minute. And I want to be respectful of everyone's time. So thank you for those of you who could join, and if other people jump on, great. I'm Genna Atiee. I'm one of the residents. I'm kind of a non-traditional resident. I'm doing my residency officially through NC State, but I'm housed out of Texas A&M. And I had a different paper selected originally, so I'm sorry if anyone read ahead and for any bait and switch. But then I thought it would be probably more helpful to myself and potentially others who are going through the modules now to do a paper that was related to module 2 and kind of reinforce some of the concepts that were discussed. And so that was why I chose this paper. And then I got too far in it to change my mind with some time constraints. So for better or for worse, this is what we're going to discuss today. So this was a paper that came out in the last year called A Comprehensive Analysis of Albuminuria in Canine Chronic Kidney Disease. And so we will jump right in, theoretically. Okay, there we go. So right off the bat, and I am not trying to be too provocative, but I think maybe that's part of Journal Club and why it's fun is we can kind of critique things and think about what we are relaying using language to our readers and what we're trying to describe. And I think it's important as we solidify terms and we use things and we use language that's as correct as possible. And I may be being too nitpicky, and I think it became very apparent that the authors of this paper are not native English speakers, and so I'm not trying to belittle their attempts. However, there are numerous things in the paper that I found a little bit challenging to accept at face value. And so this is how their introduction starts, and I just copied and pasted. And so it says chronic kidney disease is considered a frequent pathology in routine small animal practice, mainly originating from damage to the glomerulus, the place of the kidney filtration barrier. And then they cited Dr. Snabady and Sanciolo. And so I went back to those citations to see what they were pulling out. And so neither citation actually supported that statement from what I could tell. And so this came out of Nabady's paper, which actually referenced another paper discussing the progression in chronic kidney disease. This was the closest statement that I could find, saying that regardless of the initiating cause of CKD, progressive renal injury is characterized by interstitial fibrosis, peritubular capillary loss, and destruction of functional nephrons. And renal function most closely correlates with the degree of tubulointerstitial damage. And so as we're thinking about pathophysiology and applying the principles that are going to be discussed in this paper, I was trying to think of, okay, like what are they trying to say? Or if I were to write this paper, how would I potentially word this in a way that may be more easily accepted by my peers? And so I thought potentially maybe a better way to have phrased this was, due to hyperfiltration, which we expect in any of these renal states, we expect glomerular dysfunction. And it's not a very big group. And so if anybody has any comments, like it's not going to take an hour to get through this paper. So I don't know if anybody has anything that they wanted to say about that. And you can just talk or, unmute yourself or put something in the chat. If not, we'll just move on.
Well, Jen, I think that's a good point. I think that's, when we biopsy our proteinuric dogs and we're getting glomerulosclerotic lesions, and so many of our patients having FSGS as their reactive pattern, it's so easy if you start looking at the human literature and see what's described as FSGS, and it's a completely different disorder. People mostly get a primary FSGS where there are antibodies to nephrin and some other filtration proteins, and there might even be some unknown permeability factors that are there. Where our patients, I don't know if we've actually ever documented that we've ever been confident that our patients have a FSGS that is because of those antibodies or the altered permeability. Our patients is almost always from the compensatory changes to some injury. And it probably starts off being more focal and segmental, and at some point it can progress and maybe become more global, or maybe depending upon the etiology, it becomes global right from the beginning. But that is absolutely what we see so often. And it's a little frustrating because we don't necessarily have treatment other than standard therapy, even though in people that disease responds exceptionally well to steroids. That's not necessarily been the case in the few that I've seen that have attempted to have steroids that have been used to treat for it. So most of our patients are really having that secondary change, which is just that maladaptive response that we're seeing. So yeah, to say that it's necessarily the cause, well, it might be a precipitating factor that precipitates the continuation of kidney disease, but the cause might have come and gone and we're just never going to identify it
Right.
clinically or
Yeah.
even from a pathology standpoint.
Yeah, and I did kind of a deep dive and then realized that I had spent like over an hour and I'd gotten through like sentence one of the introduction. And I was like, I've got to move on. And I really couldn't find really anything in looking back at Rachel's work and some early papers looking at renal biopsies and some of those papers you have to be really careful with because a lot of I think a lot of terms were being applied potentially prematurely because of just less things that were known at that point in time. And so I just it just struck me as a very bold statement with the amount of evidence and data that we had. And so I just wanted to point that out and say thank you so much, JD, for your comments. And so then moving along in their introduction, they discussed that these were some of the some aspects that were associated with progression included proteinuria, hypertension, anemia, creatinine, and SDMA. And they cited a couple of papers, and I just pulled these just to see kind of what those papers showed. And I was kind of interested in like the SDMA in particular because I hadn't read that previously. And so this is the Perini-Pereira paper, one of the tables that I have here. And I highlighted the parts of the table that had p-values that were less than 0.05, which were assessed as significant in this paper. And these were early CKD patients. And so it was interesting if you look at their groups, SDMA ended up being statistically significant, but if you actually look at their groups and the amount of overlap between them, it's if I hadn't had a p-value, I would have looked at this and I would have probably not been all that impressed with SDMA as a discriminating factor between 13.5 and 15 with, the reference interval going to 14. So anyways, I just wanted to show that after just reading a little bit further. I don't know why my slides aren't advancing, I'm sorry. So then they also discussed the factors that were associated with survival from this Rudinsky paper. And so they talked about different things being BCS, muscle atrophy, increased creatinine, hyperphosphatemia, increased UPC, increased calcium to phosphorus product, and increased FGF23 was what was in the Rudinsky paper. That was not mentioned in the introduction in this paper, but I just wanted to be a little bit more encompassing and just for my own edification and learning, be a little bit more comprehensive in what factors have been associated with progression of CKD. This was a reasonably small paper. I think this paper, they looked at it, it was a ton of work on these 27 dogs. And they looked at obviously a lot of variables, and they did a ton of documentation. And what I really did like, even in these 27 dogs, they looked at the survival curves for each of these. And I thought this paper with Rudinsky as the primary author was their figures were really compelling. And I think you can get a lot just from looking at a lot of the figures in a lot of these papers. Or maybe I'm lazy, but I think it's really helpful to see these visual representations, and you can see, like FGF23, for example, with 450 being their cutoff. I mean, you can see a distinct difference in these survival curves, and along with any of the rest of these. So I really appreciated the work that went into this. And what we can see, I mean, UPC was another one that came out very statistically significant, and you can just look at these curves and recognize that there likely is a difference between these populations. And so they then cite a couple other papers, including one of Aiden's studies, as far as albuminuria being a negative prognostic factor for kidney disease. I think seeing what happens with UPC and survival, that's not surprising. And so this paper looked at just 12 dogs and 4 cats that died within 3 days of admission into an ICU. And they looked at, this was all-cause mortality and any disease state, and where they were just looking at just the status of albuminuria going into an ICU. And so they looked at time of death and the status of their I think it was called microalbuminuria, but urinary albumin. And just dogs that had albuminuria were at increased risk of death. Again, a seemingly all cause. They didn't have enough cats, I mean, to, I think, make any statement. So if you were a cat, though, it didn't seem great to have significant albuminuria, given that 75% of them died. So that's kind of the background of why they were interested. And so their aim and what they were trying to do was to define the relationship of albuminuria to a surrogate GFR marker, such as both creatinine and STMA, and then compare albuminuria to proteinuria through UPC and determine its relationship to hypertension for early stages of CKD, meaning IRA stages 1 and 2. This was a retrospective case series. So this was a university hospital in the Czech Republic, where they had a total of 102 dogs that were able to be assessed for the study. They divided those into 4 groups. This is a little bit interesting because if you were to read the paper and look at their supplemental data, I will show a graph later that shows a 5th group. I don't know what that group is or where it came from, but these are the 4 that they discussed in the paper. And then there's this secret other group 5 that I don't know who or where they came from. So spoiler alert. And so their inclusion criteria was they had to have a normal urine sediment exam on a urinalysis, and they had blood pressure that were measured in 53 dogs. And remember, part of their aim was one of their later goals is to then look at hypertension and albuminuria. And so that was done in approximately half of the total group. And this is retrospective. And then they also were interested in markers of GFR, and they included SDMA, but that was done in even fewer dogs of 46. And there were 37 dogs of this 102 that had both an SDMA and a blood pressure. And so there are 4 groups, and I have in parentheses the number of dogs per group. Was they had normal dogs, which were like coming to the hospital that for not sick visits, and then their early kidney dogs, Iris 1 and 2 dogs and there was 42 in that group, so that was the largest population. Then they had acutely ill with normal renal function. And the acutely ill with normal renal function, if you looked at what these dogs came in for, it was a huge myriad of things. But there some were GI, and those were like sounding like maybe the most sick acutely ill, but some were like ophtho issues, some were lameness, some were skin. It was like a myriad of body parts that could make them present to a hospital. And then the chronically ill had 13. And I think importantly, when we're talking about any type of proteinuria, this chronically ill group contained endocrinopathy patients such as Cushing's and diabetics. And it doesn't describe their how well controlled they are or much about those dogs. And so I think that's a little bit convoluted to tease out as far as when you're looking at one of these markers and comparing it or trying to use it as a potential marker for CKD, if you're also comparing it to dogs who may have other disease entities that could make them proteinuric. So this was their study design, part of what I just described. So they're sick and they're healthy with 102 dogs. Healthy dogs, they had to have a CBC, a chem, a urine biochemistry, which they didn't honestly further describe. And they had 10 that had a blood pressure. And then in their sick dogs, which could be any of their other groups, they had an abdominal ultrasound, which is important because one of the ways they identified CKD was based on renal ultrasonography, CBC, chem, again, urine biochemistry. Potentially that is a dipstick. It's unclear. And then 43 of them had blood pressures. And so all of the acutely sick animals had to get over their disease at some point in time to be included in this group, which I think is a relevant statement. They also talked about indexing the age of their animals to weight, and this was in their supplemental information. And so I pulled it here. So later on, when they do some of their statistics and compare their values to the indexed age of the animal, this is what this is. And so this is this weight of dogs in kilos compared to their age, showing that bigger dogs age faster. And so you could have, for example, like an 8-year-old dog who would be considered an adult if it was a 9 to 22 kilo dog, but it would be considered a senior dog if it was a 22 to 40 kilo dog, as an example. Okay, so the diagnostic criteria that was used, they used UAC in this paper as urinary albumin to creatinine ratio. So they compared that between age groups, and then their diagnosis of CKD, they said, was based upon, quote, clinical signs. That was not further described as far as how that was determined. I assume polyuria, not sure. Changes in chemistry, which included an STMA greater than 14 in the patients that they had STMAs in, serum creatinines greater than 133 micromoles per liter, which is the units that are the international units that correspond with IRIS, or a BUN greater than 10.3, and abnormal kidney ultrasound findings. And then hypertension was evaluated using a Cardell, and they stated that they followed the ACVIM consensus guidelines, and no additional information was given to that. They determined their urinary albumin to creatinine ratio based upon this formula, which has been previously published. It's interesting, and I haven't actually made sure of this, but if I look at this and if I look at the units, it does not look like all of the units would cancel out. And throughout the paper, they sometimes have units associated with this and they sometimes do not. In the original paper that this was referenced from, they used a slightly different formula, I think because of international units, and their units did cancel. So I did not do any more math, but just FYI. So when they used previous reference ranges for UACs as being physiologic being less than 30, microalbuminuria was 30 to 300, and then macroalbuminuria was greater than 300. And their UPCs were the same as IRIS as far as substaging. And then this is their UPC formula, which is the same one I think that most of us are familiar with. Hypertension was not further divided. And so they looked at hypertension based upon a blood pressure on a Cardell greater or less. So I assume it was systolic, but also not explicitly stated that I recall, greater or less than 160. And so if it was 159, they were considered normotensive, and if it was 160, they were hypertensive. And so that was a binary value, but they do plot that based upon the values that they got, which we'll see. Their data was very right skewed for UACs, and so a lot of the statistics were based upon the log or the natural log. And so I did appreciate the transparency of showing the original data set in comparison to their transformed data set, so that you could see how it was normally distributed after transformation. And so that's what these are here. There's just as a preview, there's like 10,000 images for this paper. So hold on to your britches, because there's so many images that all say the same thing. So we will get there. So then for their statistics, they looked at a correlation between UAC versus UPC, and then they assessed that based on Pearson's correlation coefficients for the log transform values to make it normally distributed. And then for their non-parametric Wilcoxian rank sum tests were used, and then to look at differences between groups. And then confidence intervals were constructed by bootstrapping. I didn't know what bootstrapping was. And so I looked it up, and it's where you use the same data set, and some software like rearranges them in different ways so that you can then mathematically kind of determine what a reference interval would be. And so what the expected reference interval, so therefore then the confidence interval within that data set. And people would do it in cases where they don't have enough data or enough previous experience to have a good sense of what their reference interval should be or confidence interval should be. So that's probably not the most accurate description, but that is what I took away.
Yeah, and thanks for explaining that. I think it's something that's interesting to note, because it usually will indicate that the data set's not as robust if you have to bootstrap it for something when you're looking at observations. Bootstrapping is more often done in predictive models, where you're looking to see, okay, we've looked at this population, and now we have this model for something. Let's run a number of variables to see how well the model will still predict. And then that's essentially referred to as bootstrapping. And then you can apply that and say, well, based upon our assessment of variability within some of those models, this is what we think the model's variability might be when applied to real world observations. But when you're not doing it with modeling, and when you're trying to apply it to your observed data set, you're basically saying, well, we don't have a lot of confidence in the replicability of the data, so let's do some modeling to see what it might look like. But then that gets lost when you would then maybe just grab the table and look at it, and then you look to see what their confidence intervals are, because it doesn't note unless you read the stats that it's done by bootstrapping. And it's certainly not going to have the same robust clinical confidence that I would have in that confidence interval when it's done by bootstrapping versus here's the observations that we were able to see. It's a way that you can essentially say, when our confidence intervals were like really huge because our data was so heterogeneous. So let's bootstrap and do 1,000 simulations, and that will smooth out some of that variability because they'll end up being more outliers, and it could actually make it look maybe a little bit smoother in the end. But you don't get that when you just look at the table and you see what their confidence intervals are. So it's statistically acceptable, but clinically you would feel less confident and comfortable with their overall conclusions with the methods they used.
Yeah, that's helpful. Yeah, that I hadn't come across, well, I don't recall at least paying enough attention to have come across that before, or having, so that's why I looked it up. And then it's just, it did seem it did seem like, based upon the type of study they were doing, atypical, at least for like a retrospective observational type study. But so I appreciate that clarification. Well, and we will get there, but thus far, I hope I don't offend anybody, but I think I think all of us will be a little bit cautious with our interpretation of a lot of things. So, so this is their basic study population characteristics. We've shown this in multiple different ways. Probably relevant are the ages. If you look at the age of their populations, you can see that the healthy control versus CKD versus the acute SICs and the chronically ills, there's a you can just eyeball it and see that there tends to be a difference in these patients. And so the chronically ill dogs average is 10, the median is 10, and the acute SIC is 4, and the CKD is 9, and the healthies are 2. So there seems to all be some pretty big discrepancies there. And otherwise, like eyeballing it, it seems like there's some variability in weight as well. There's not much discussion on that, but that's just when you eyeball the overall data set. So this is a nice graph. I liked this graph, and I can look at this and say, yep, that'll make a line. And I say this because we're going to move forward to some other polka dots soon, of which the correlation is a little bit different. So this was their log. Again, everything was transformed to the natural log, UPC versus UAC. And they seem to have a nice correlation that makes physiologic sense. So I was good with that. Their R value for their Pearson correlation coefficient was 0.91. That's close to 1. That seems okay. I'm on board there. Sounds good. And then they looked, okay, so they looked at those, said they assessed those values based upon what they would consider pathologic proteinuria with a UPC of greater than 0.5 or a UAC greater than 30. And then in 87% of cases, those two agreed that those would be pathologic. In 3%, only the UPC was abnormal, and in 10%, only the albuminuria was abnormal. Okay, so those seem like they're highly correlated. A couple dogs that you would catch in one and not the other. And this is their positive and negative predictive values for their area under the curve. And we will see another graph soon, how they got here. And this is that graph. And so I had a hard time with this, and maybe it's my experience. So this is their ROC curve for their albumin to creatinine ratio, and looking at its quote adequacy as a test, and then they color coded it. And here's where area under the curve, I'm good with. But here's where things for me get a little bit confusing. So then they say the color scale represents the base 10 logarithm of the UAC as a threshold used to reduce kidney function. So that was, they got, when they used a value of 10, they said that had the best, that was their best threshold with the best sensitivity and specificity. And they have this on this graph here as this marker. And I am not like, I look at these I look at the colors, and they have this color scale on the y-axis over here. And if you look at this, is their false positive rate. And so this, they're saying, if you follow across here, it's, you know, that you're at this 2.46, which actually makes no sense. And so but then I thought maybe this is actually this teal color over here, and they're somewhere in here, and that's where they came from. And they don't describe this further. And so they talk about, for this threshold, the false positive rate is 11. And 11, if this is a rate, would be like around, you know, between 0 and 0.2, which eyeballing this, it doesn't really look like you're there. This looks like it's further over. So overall, I had no idea how to utilize this graph in what they were saying. And I tried to look at their color coding. The color coding here, maybe that's what they're talking about, is it's over here. I don't know why that y-axis looks like that. So if anybody has any thoughts, otherwise we'll move on.
Yeah, I can't help you on this. I mean, I feel like we look at AUC, ROC curves all the time, and I've never seen it plotted with like another axis on it. So I don't really know what they're trying to do, and if it's valid. Maybe it is, but it's certainly not something I'm familiar with at all.
Perfect. Yeah, I spent way too much time staring at the rainbow of colors here, and eventually gave up. So, okay, so I talked about polka dots a few slides ago, and here is what the next two slides are, the slides of polka dots. So these are their correlation plots, and they're going to make some statements about quote strong correlations coming up. But I want to I think pictures are worth 1,000 words here. And I don't know about any of you, but when I look at these polka dots, I am not seeing a lot of lines. So here's our second sheet of polka dots, and I have the ones highlighted that they ended up stating there was a statistically significant correlation. Some of these things they state with a lot of confidence. They will eventually talk about the fact that SDMA was better than creatinine. If you look at these plot graphs, I just visually, I have a hard time with that. They're also going to talk about their erythrocyte parameters. And then blood pressure, and this is what it looks like a Dalmatian to me, but so you can burn that into your brain as we move on. And here is a table representing these things, and here's their R value for these things, and so and they were nice and like described how to interpret an R value, so that was nice of them. But if you look at the R value, so you have the UPC to the UAC, that was the 0.9 that we saw, and then everything else is nowhere close to 1. SDMA was their strongest predictor at 0.56. And so that's the data. And and then we'll eventually get to their conclusions, but I think that I just think that the raw data is, I think, very telling personally. And they have 10,000 graphs in this paper. So, and I'm not going to bore everybody spending a lot of time on them, but here's, these are their groups, the groups being healthy, chronic kidney, acute sick, and chronically sick. And they are showing these with their albuminuria and UPC. And you can get a sense that chronically sick, I think the moral of the story, what we're going to see in 12,000 graphs plus, is that the chronic kidney disease dogs and the chronically sick dogs, who again were mostly diabetics and cushionists, there's a lot of overlap. And there seems to be separation between the acutely ill, which was like, you know, seemingly not very systemically affecting illnesses, and albuminuria and UPC, were the healthy dogs and those dogs were much lower, and then the chronically sick dogs and CKD dogs were higher. This is effectively the same data. Okay, so once again, you have your medians of UACs for healthy controls. It was about 2. CKD was 54, acutely sick was close to 6, and then chronically sick was 104. And then this again, it's the same stuff, both with UPC and albuminuria, and it all says the same thing. This is from their supplementary data, and this is the same thing, the UPC and the UAC. And then they look at it versus age. And I don't know why they did this. So I included other tables to make it more clear. So they divided ages based upon that index that we talked about before. And so that is, the groups would be young, adult, senior, and geriatric. Their color codes for the graphs are not the same in each graph. And so in graph number 2 that I've provided, which at least is in the right order of how something ages, going from young to geriatric, the first graph they show in the paper starts with adult and then goes to geriatric and then goes to senior and then goes to youth. And they are not, the youth color is the same as the geriatric color in a different table. And so it is very confusing. So I included the supplemental data because it was at least in the same order of how most people think about age chronologically. And the colors were consistent with other things. And then there's this supplementary figure that they provided. And then something that was incredibly confusing is now there's a 5th group. And I don't know where it came from. I don't know what this group is. There is no mention of a 5th group in the entire paper at any point in time. The whole paper describes 4 groups, and then there is this 5th group that's just like this surprise when you're looking at the data. So I don't know what to tell you about that. Okay, so it seems like with age, albuminuria increases, is what I think I have gleaned from all of this. And then they look at UAC and hypertension. And here is the log of UAC versus blood pressure. They claim there's a good correlation. I find that challenging to visually appreciate. And then this is the same data plotted in a different way. And then they added on top of that UPC. And so it says, so what they did was they have each little symbol is a patient and a value from that patient. And they have normals, which are in circles. And so those are all of these guys. They have microalbuminuric patients, So that would be like the 30 to 300 microalbuminuria. And those are triangles. And then they have macroalbuminuria. And so this was, I think, the strongest case I circled here, that in these patients who were more severely hypertensive, all of the severely hypertensive patients that they had, which was 4, so take that with a grain of salt, but all of the more severely hypertensive patients all had macroalbuminuria, which would be very consistent with what we've seen with, UPCs historically and hypertension. So at least that gives credence to, I think, the fact that that makes sense and is what you would, that is a physiologic response that I think we would predict, which makes me feel a little bit better about some of the observations. Okay, so then they go to the discussion, and but I'll pause and just see if anybody has anything to say about any of the results before we move on to the discussion, which is going to be really brief. Okay.
Well, the discussion is the least important part of the paper because it's the authors sharing what they think. And I think clearly looking at the data, the conclusions are not going to be the same as maybe many of us that are reading it, and where we might be able to draw lines across their scatter plots, we probably would draw different lines and whatnot. So I think you did a really great job of summarizing the results that are there, and we can certainly criticize the maybe overreading of their results, which it seems like they might have done a bit.
Yeah, I completely agree. Like if I were to review this paper, like every paper, it seems like when you review, it's like, are the conclusions supported by their results? And I would have a very challenging time checking yes. So their conclusion, so they discuss, there was another recent study that looked at UAC, and they had a reference range up to 19, and they just discussed, why they used 30 for theirs based upon some other studies. That their area under the curve threshold of 10 mg per gram, or the units they used here for albumin to creatinine, had the best sensitivity and specificity. And then they gave a lot more weight to STMA than creatinine because of the fact that it had higher correlation to their data. I think, we've all discussed limitations of creatinine, but I think in general, creatinine, this is my own opinion based upon what I've read from other people's, I think, really good work. I think creatinine with a single reference range and using that as the end all be all is problematic. But I think creatinine, when applied appropriately, is a pretty good marker of GFR, actually. And SDMA, I think, has just as many limitations as creatinine. And so I think people should be very cautious if they were to read that statement alone with how these authors applied the limitations of creatinine. They didn't discuss, I believe that they used creatinine as like a single reference range, and didn't discuss any type of breed-related changes in creatinine, or if a single patient's creatinine changed relative to its own previous values, etc. And then they stated, because of their own data, that UAC is likely more sensitive for reduced kidney function than creatinine. And it's hard for me to really understand the validity of that statement, particularly when you look at their patient populations, including those patients who were presumably did not have kidney disease and who had the chronic illnesses. Those patients had actually overall more microalbumin or more urinary albumin than their IRIS 1 and 2 dogs. And so I just have a hard time with that statement at face value. And so
they're also different concepts too. Like,
yes,
urinary albuminuria is not necessarily a marker of reduced
GFR.
Kidney function. It can be a marker for structural integrity problems.
Yeah.
So you could have a normal GFR, but you could have leaky glomerulus, and that doesn't mean that your function has decreased. Now, if it if we're truly talking about albuminuria and it's resulting from a defect in tubular reabsorption, and then maybe, but we can't say that for sure because it could just be overwhelmed because of
Yeah,
we've exceeded the Tmax because we're
right.
leaking too much albumin across the glomerulus. So it's a confusion between the structure and the function of the kidney. And so just conceptually, it's not a valid statement that they're making, whether we disagree with the stats or whatnot. It just doesn't, it's not physiologically appropriate.
Yeah, I completely agree with that statement. Um, some of the limitations that they added were they used two different chemistry analyzers. They had lower numbers. It was retrospective. Age matching between groups wasn't possible. They didn't have, they put a lot of weight on estimate. They didn't have that on everybody. And then this is my own limitation I added. I just said the conclusions are stronger than the data. And an example of that is this is their statement I pulled directly from the paper verbatim was UAC, quote, strongly correlated with STMA levels as well as with the RBC hematology parameter. And then I just copied and pasted their table 3 to compare, and you look at that statement in comparison to their R values. And I, unless I've been utilizing Pearson's correlation incorrectly, for a long time, I just can't agree with that based upon the numbers in front of me. Um, and that's it. Um,
Excellent. Excellent. Well, I was actually, sometimes it's fun to read a paper that you get angry about. Sometimes it's torture, but I think you did a great job of looking at everything and being skeptical with their results and maybe reading it a lot differently. And honestly, I agree. I'm surprised that it actually got through review with the statements that they're making because I don't know I don't agree with so many of them just from pure definitions from statistical terms. Really nice job. I think that for me looking at it like, okay, well, what does this do? Does it change anything? I think the most interesting factor that they had was the correlation between UPC and UAC, which was
yeah,
pretty strong. Because certainly one of the things that's been shown in people is if you there are different diseases, glomerular diseases, that will have a uh, a variable albumin to protein ratio, meaning, let's say for most of our patients, the UAC contributes to 75% of the UPC,
mm-hmm.
but there are some disorders where and certainly you can think of the classic one being like myeloma, where most of those proteins are going to be Bence-Jones proteins rather than albumin. Clearly, the UAC is going to be much lower in those patients, but the UPC is going to be higher. But there are plenty of other disorders that in people, that ratio is different, and they can use that as a way to have a higher suggestion. It's not strong enough that it's a diagnostic factor in its own, but they can use it and say, oh, based upon this, we're leaning more towards this differential as the patient's underlying disease. And as far as I'm aware, even with our patients that we have biopsies, like we've never looked at that to see how much of their UPC can be accounted for by albumin. And is that different amongst our patients with immune complex GN, amyloid, FSGS? Because maybe that could be a test that could be helpful for those patients that we can't biopsy for some reason. So I thought that was really interesting, but certainly still fuels the need to do a follow-up study to differentiate it based upon histopath results.
Yeah, I had similar thoughts actually, and I actually thought about as far as one of the reasons why I wanted to do a paper with albuminuria is because I'm quite spoiled being here at A&M right next to Jess Hokamp's lab, and so we do quite a few STS pages really really frequently, but that's really labor intensive, and there's a time delay because of that. And so it was, I thought maybe I need to kind of explore some other options for some of these patients. And, would something like an albumin to creatinine ratio be supplemental or helpful in interpreting some of these dogs, particularly those, with like intermediary amounts of proteinuria, and you're like, okay, is this going to be more likely, to be tubular versus glomerular, and you know, could you use something like an albumin to creatinine ratio to just get a better sense? And if you compared like total protein versus the albumin, you know, component of it, similar to like what we do on a gel, you wouldn't see, you know, how many were, you know, small proteins, but you could maybe kind of like you look at a total protein and an albumin as far as total solids versus your globulins, you can kind of make a rough, you know, I get a rough idea. And so I was thinking, you know, it would be interesting to just, from a quantitative perspective, look at some of the patients who we've done gels on and run UACs on them, assuming, you know, their creatinines have been stable for some time. And that I don't know, all right, because I think there's always a limitation if the creatinine is jumping around. Using that in a non-steady state, I think can potentially lead to some erroneous interpretations. But I do think you're right. Like it does, at least if nothing else, this has led to considerations for additional uses or studies to be done. JD, were you just able to draw on the slides?
Apparently, without knowing how to do it, I'm on my phone, and so I was trying to fiddle with the mute buttons and whatnot, and I was like, somehow I'm trapped drawing. At least I didn't draw penis, which has
Nope,
happened
nope,
in previous
nope,
rounds. So,
no. Thank you. We're all done with that. Thank you. I have to post these online. JD Foster.
but yes, it was me. I do take credit for it. It was unintentional.
That's good. It's like, you know, little jets of pee.
There you go. Well, thanks, Jenna. That was awesome. I really appreciate the real deep dive you did into it. That was a lot of work, especially to uh, second guess a lot of the claims. So thanks so much for doing it. It was a really fun discussion.
And thanks so much for all your thoughts. Everyone, I hope
Yeah.
will have a great day. I don't know if there's any more journal clubs between now and
No,
then.
you're the last one of the year, so
Well, happy holidays to all.
all right.
And to all a good night.
And to all.
Thanks. Bye.
Cheers.
See ya. Bye.